Good afternoon and welcome to Summiting Mount Meaningful Use 2, a complimentary webinar from healthsystemcio.com. Just a few housekeeping procedures. My name is Kate Gamble. I'm the managing editor at healthsystemcio.com. I'll be moderating this event today. We encourage you to ask questions. We're going to hold a Q&A session after Tom's presentation. You can submit your questions at any time by clicking on the QA panel located in the right corner of the screen. Type in your questions in the text field and hit send, and please keep the send to default as all panelists. As you see on the screen, there's a link for downloading the deck. There's a shortened URL at the bottom of all the slides. And you will receive an email when our archive recording is ready. So on the agenda today, we have Tom Johnson, who's the CIO at Penn Highlands Healthcare, and he's going to talk about meaningful use 2. Okay, Tom.
Thank you, Kate. Hello, everyone. Again, my name is Tom Johnson. I'm the CIO for Penn Highlands Healthcare. Penn Highlands is a 4-hospital health system that is situated in western Pennsylvania, specifically in rural western Pennsylvania. We have about 9,000 people in the city of Du Bois, which is where Penn Highlands is headquartered. Before I get into too much of Stage 2, I just want to give a brief overview and how we positioned ourselves to be the first hospital in the United States to successfully attest for the Stage 2 requirements, which we did the morning of April 10th when the website opened. And it really is a story of we spent 5 years really positioning our EMR and making sure we exceeded all the Stage 1 measures almost to the point of 100% across the board. So that really positions us very well to be the first in for Stage 2. So as far as my slide deck, if you look at the Stage 2 overview, I'm not going to drill down into all the individual measures. I think at this point all the listeners are probably very familiar with the measures and focused on the ones they're struggling with. So as you know, the key is you have to have 2014 certified code before you can attest. There are 16 core measures, 3 menu, and 16 quality measures, the total which are significant compared to Stage 1. They did raise the bar, and they did add quite a few measures, which had made it very interesting and challenging. The next slide, the biggest challenges. Working with the various vendors, we have 4 different EMRs in our health system. So I know many of the vendors were struggling to provide the 2014 certified EHR code. Even when we did receive it, we found a lot of issues with many of the vendors that we had to go back to then and have them make corrections. Trying to be, first in, we stumbled upon far more issues than we planned on. So I think the very first challenge that we all face is that the vendor community has the same regulatory burdens that we have, and that they have to get their code ready and delivered in a timely manner. The 2 other big pieces that I think are unique to Stage 2 that were our biggest challenges, and I'm assuming would be very similar for everyone else, is the patient engagement. Really getting patients and families engaged in their care really changed the game. In Stage 1, we were able to control almost all the measures within the 4 walls of the hospital and quite frankly in the IT department where we could make most things happen. Now you're reaching outside the hospital and you're trying to get patients and their families engaged. In our area, we have an aged population, which I'm sure most people do as well. Many of them don't have email addresses nor care, so it is a real challenge to get them interested in and get enrolled in a patient portal. The second piece of Health Information Exchange, or HIE, that's a very big challenge as well. It's technically very complex to set those up. It's difficult to use the direct system to exchange CCDs. When you're the first one in, who do you exchange with? Nobody else or very few partners in our region had any exchanges set up. So we'll drill down into that one more, but I wanted to just start with going over those challenges, and I'm assuming that most people are facing those same challenges. Our methods going forward is we keep a tremendous amount of pressure on our vendors. We don't let them delay. We set deadlines. We hold them accountable. We escalate to the senior level because without the code, you really can't do anything. So put a lot of my personal effort on establishing relationships with the key people at our vendors and keeping the pressure on them to deliver code and give us good roadmaps on where they're heading and when they expect to be able to deliver general available versions of code. As far as getting those patients engaged and their families, we did hire a full-time nurse that really tracked down every admission during our 90-day period to make sure that the family was approached, the patients were approached, and they were educated on what our physician portal could do and how they could benefit, patient portal, how they could benefit from the information, which is how we were able to meet and exceed that measure. And on the HIE piece, we basically just built our own. And struggling with the other health systems and partners in this region, we built our own HIEs and created web inboxes for our physicians to make sure they could get electronic versions of the CCDs or patient summaries and meet those measures. We did have a number of false starts. So as I already described, we did find a tremendous amount of bugs in our software. Our certified code, which I find interesting, how can it be certified if it doesn't work? But it is certified, and there were plenty of issues that we had to kick back to the vendors and create workarounds for and help them troubleshoot the issues and then actually get the code programmed and take the next fix. And sometimes the fix breaks something else, so then there's another fix. So that was a very iterative process that was quite frustrating for us. The second one is that we really thought that we could get engagement from nursing to approach patients and to get them enrolled in the patient portals. That was a no-go in that nurses basically just too busy doing too many things, not being as technology-friendly as we thought and hoped. So that's why we basically had to deploy our own basic nursing personnel directly out of the IT department to make that happen. And we also made the assumption that others would be happy to share CCDs with the HIE portion because they also need to meet the measures. But to our dismay, many of them would not do it either for competitive reasons or were just not in a position technically to make that happen timely. So we had to figure out creative ways around all of these issues simply to survive and to meet the measures and keep us on track. I was asked the question many times why there were so few organizations to be able to successfully do this. And, if you look across the spectrum of EMR providers, even to this day, there are providers that are still struggling to provide certified code that actually works. So it's kind of unfair for organizations that have selected an EMR provider, made their investments, understand the regulatory requirements, but they don't have certified code. So they're not in a position to attest. They're not in a position to do anything until they get that code. And if you look across the whole spectrum of EMR providers, there's certain ones that are still struggling badly with providing that code. We talked about engaging patients. That's incredibly difficult work. As I said, we have an aging population here. We have some very sick and acute patients here. The last thing they want to do is talk about how to enroll in a portal and get their results electronically. And there's also a big assumption that they have their entire electronic medical record available to them. That's certainly not the truth for us. I think very few organizations are in a position to provide that. We have to run everything through various committees that are physician-led that have to agree to that information to be released. So we have limited that greatly to just very specific subsets of results. So that's something that we're still trying to build upon to add more value for patients because there might be certain types of procedures or service lines that we provide that you cannot get results for because we haven't been able to get that approved by our committees and our physicians that are engaged in those lines of service. So it limits the value to patients, which then limits our ability to convince them to enroll. So that one will be an ongoing, forever issue of trying to successfully balance and navigate the needs of patients and the demands and requirements of our physicians. Building HIEs is incredibly tough and expensive work. We've soaked a tremendous amount of our budget into that process we've been working on it for many, many years, trying to figure out how to do that for all of our different EMRs, which we have more than 10 in our health system. Yet in all of our independent physicians in our community, as well as some of our health system partners. It's just a tremendous effort to do use cases on all those types of results, build all the interfaces, and deal with all the nuances that exist, not only politically, regulatory, the competitive nature, the different demands and customizations of the providers that basically consume them and their office staff. So that one I can see going on for many, many years as well. And the last thing is there's just so many initiatives going on, from regulatory initiatives. We still have ICD-10 looming. There's RAC audits. There's performance incentives like the readmissions and never events and hospital-acquired infections. And if you look across the boards, ACOs, patient-centered medical homes, all the different health system building and consolidation. How do you get it all done? So some of the larger health systems may not be as focused on meaningful use stage 2 as we are, because they have other much larger, much more important initiatives they're working on. The new Obamacare exchanges, the health insurance exchanges, just a tremendous amount of effort and resources going into complying with all those different initiatives. Will the total increase? I think it will. I've been tracking it very closely. So in May there were 4 hospitals that successfully attested. That number went to 10 in June, and in July there were 78 reported by the ONC. So we'll see what it is in August. Maybe it's it goes over 100 as far as the total. But if you think that there's approximately 5,300 hospitals in the United States, that number may be skewed because of acquisition and health system absorbing smaller hospitals, but those facilities still exist and can still attest. So it's still a very small fraction of the number of hospitals that are operating. And even on the physician side, which I don't list that number, but it's still a small fraction of the number of independent and group practices that are out there. So we're well off the mark of what they're expecting to be at. And a lot of those things I previously mentioned, just as far as the difficulty, the cost, the vendor community, and the number of initiatives going on, I could see that there's going to be great changes to the program. So in total, for the federal fiscal year 2014, I don't see significant increases. I don't see a large population of hospitals as well as physicians meeting the requirements. So in my opinion, I do think the ONC and CMS overall will be forced to lower the bar and to make it more flexible and easier for organizations to attest. I think they'll get tremendous pressure from Congress to make that happen. For the amount of money that's been spent and the incentive dollars that have been offered and received by many organizations, they're going to certainly demand better results than where we're at now. Let's go to the next slide there. I've been asked the question, did they overshoot? And I think the obvious answer is yes. I think that they would think that they would be well over 50% by this point for stage 2, and they've overestimated the vendor community and their ability to R&D in the regulations and meet the requirements and deliver to their customers and do it timely. The total regulatory burden is breaking the backs of many of the small hospitals, some of the medium-sized hospitals, certainly the independent physician practitioners. I've listened to many of the public hearings that the ONC have hosted, and you can hear very clearly from some of the individual practitioners that the regulations don't make sense for them in all situations, and they're too expensive, and the burdens are too great. Patient engagement, like I spoke about previously, is incredibly difficult, and the HIE piece is incredibly difficult. So when you add all that up, it's just too much for many organizations and individual practitioners. Talk about stage 3. If we can't do stage 2, how are we going to do stage 3? What's going to go in stage 3? My guess is that it will have less impact. Even for us, as let's say we're the leaders or one of those leaders in this, we've received all of our incentive dollars. So we have 4 successful years of attestation, and we've received the maximum amount of incentive dollars. So that alone is a deterrent for stage 3. And if you look at the continued investment we're going to have to make at the same time we have ICD-10 looming, it becomes very challenging to say we can continue to raise the bar on meaningful use requirements. Everything I've read is that one of the big focuses for stage 3 is going to be, more focus on HIE and interoperability. If we're stumbling on stage 2 to make that happen, it's not going to set the stage well for stage 3 to do that. I would personally like to see more incentives put out there. I think those big dollars really get people's attention and really kind of navigate focus. If those dollars disappear, which for us and for many organizations they will, even if that's the incentives switch from positive to negative incentives, the negative incentives, if you really drill down into it, there's really not a lot of teeth to those as well. When you're looking at 1/3 of 1% of a Medicare market basket increase, it's just not enough. And going forward, how big do you think that Medicare market basket increases are going to be? When they get down to fractional percentages, the impact's just not there. And, the amount of quality measures are set to continue to increase at a relatively significant pace. I don't even think we're doing a very good job with the ones we have now. Many of them we've reported, the numbers are so skewed and not truly reflective of the quality that we're actually providing. And in my opinion, I think we need to focus on making sure our quality measures are quality, meaning that they actually reflect what we're doing and they're valuable. To report garbage numbers and just continue to increase the amount of garbage numbers is really not helping ONC or CMS, and it's not giving them a good indication of the work that's truly being done. Cost benefit of the Meaningful Use program. For us, it has truly been transformative to our organization. From when we go back to the 2009 time frame, when we really look at where our organization was at, where our focus was at, we were the HIMSS 3 organization. We had a lot of departmental-based systems, but we're mostly paper-based. We lacked all enterprise-level systems. We truly embraced meaningful use. We purchased the systems and the EMRs that were fully integrated across the boards. We engaged our physicians at the highest level, where we made modifications to medical staff bylaws. We made major changes to the leadership. We got our board of directors involved. We focused our investment completely on meaningful use and the underlying infrastructure and technologies to make that happen. And we saw huge benefits to patient safety and quality. Our organization is almost a HIMSS 7. We're very close to achieving that. So we basically went from 3 to a 6.5, and hopefully very soon a 7. We've made major gains in reducing medical errors as far as medication errors, as far as delivering patient care more real time. So we've embraced a lot of quality measure dashboards that in real time tell us when interventions need to be done. And that's been witnessed across the boards in our organization. Now, physicians complain that they do more than ever, that they've become secretaries because they're literally spending most of their day entering data and documenting what they've done, capturing quality measures, capturing meaningful use measures, using e-prescribing. And that is one of our major focuses now, is to streamline that process and really improve their workflows. But prior to that, they shouted orders and they scribbled on papers. So it's been hugely transformative to our organization and to our patients that receive the services that we provide. A huge spike in quality across the boards in the right direction for us, and that's been witnessed in our reports from our benchmarking studies from CMS, from other independent consulting groups that we've hired. So we've got a better handle on our costs. And we certainly have noticed huge amounts of improvements in our quality, and we've received a number of awards for the improvements that we've made in our quality, as well as from the Joint Commission in our State Department of Health. But to be honest, there's a huge increase in our IT spend. It's unavoidable. So our fixed costs for IT have increased significantly, and that's not going away. So that's something we're going to have to live with, budget, and continue to find ways to fund and source that. So when you're all in on IT and you're all in meaningful use, it has to be sustainable. So we've made major investments that will continue to have to be funded in our operating budgets. We've made significant amounts of increases in the number of staff and the training they've received. We've pulled in subject matter experts from every line of business and have them cross-trained into IT, have additional job descriptions that have matrix reporting back to IT, just to make sure that we have that expertise. And we recognize only having one person in a department with that expertise is a flawed plan, so each department now has a backup person as well that's received that additional training and those additional addendums to their job description. So that's been very important. And then my last bullet point is physicians are dissatisfied. They don't like the idea that they can now be very closely monitored, measured, benchmarked, and compared, and quite frankly spend most of their day on a computer versus in the patient's room and treating patients. So that is a new focus of ours, is really drilling down into how many clicks it takes for them to do everything. Are there ways to combine or consolidate the information they need, leveraging voice recognition and other enabling technologies to make their jobs more efficient and more productive? What has meaningful use done to either influence or reduce innovation? And has innovation increased? I think it absolutely has. It's from our organization and from what I see in the market, meaningful use and the adoption and implementation of EMR systems across the board has created a firestorm of innovation. I see more investment in startup companies, venture capital funding in health ITs at record levels. I think it was either last quarter or the quarter before it finally eclipsed $1 billion in investment from VCs into new IT startups in the healthcare market. You see a lot of the large health systems have now found ways to monetize and spin off a lot of their innovations and intellectual property into new revenue streams, new line of businesses. So some of the big ones are may have incubators that have created 40 or 50 new health IT companies, and I see more and more of them diversifying their revenue stream into that kind of thinking, where they're looking for opportunities to disrupt lines of business with new technology that they can then monetize and turn into profitable businesses. In the area of mobility and mobile applications, you probably can find a new app being rolled out every day in the healthcare space. It's truly exploding, and I think it's in response to the market of what everybody's seeing as far as EMR implementation, patients engaged in their care, the new age of consumerism, where employers are shifting more of the cost of health insurance to their employees. So as employees have to pay more, they're going to understand and care more about what they're doing, and they're going to want tools to be able to manage that better. So I do think that innovation is going to continue to skyrocket as people are looking for better ways to provide care and to reduce the cost, and looking at new payment models as bundled payments come in and organizations and providers take on more risk. They're going to want the access to big data. They're going to want powerful analytics to really manage their risk and their cost. And I think there's more to come, more than ever. I think we're just seeing the beginnings of it now. Is the focus of meaningful use correct? I think for the most part it has been. I mean, the real focus is how do we improve quality? How do we improve patient safety? Because ultimately, if we can do that, the real hope is we can start to address the cost issues. When you have readmissions, when you have hospital-acquired infections and conditions, if we're making patients sicker and we're driving up the cost, that's not good for anybody. So really leveraging the technology to deliver care and deliver care in a new way that's safer, that we can truly measure and manage and find the weaknesses in the delivery system is how we start to address the overall problem. I know it's more complex than that. I'm simplifying it, but certainly, health IT has made a huge difference for our organization. I have to believe it's making a big difference at other organizations as well. So, does every measure make sense? No. And I don't think anybody could write a program that addresses everybody's challenges and everybody's nuances. For most part, you can be exempt for certain measures if they don't apply. And I do think that the government has offered some flexibility around that. I think there's more flexibility to come specifically around stage 2 going forward. A lot of the issues where providers drop the ball is during transitions of care. So whether that's sending a patient to surgery, transferring them to another unit, from the ED to the inpatient side to home health to long-term care to other tertiary care facilities, that's when the ball gets dropped. So if we can do better with HIE and the transitions of care to make sure that the information and the meaning of that information, the context in which it was captured, gets transferred, that's going to do a lot to improve quality and improve patient safety. Inherently, it'll reduce a lot of the duplicative testing that's being done because they don't trust the sending organization's information, which will pull cost out of the system as well. So I do think that transitions of care will continue to be a big focus with the regulatory organizations and certainly from a technology standpoint. And the last piece is, where does the patient come into this? Where's their responsibility to do the right thing, to stay informed, to follow the protocols and be compliant with their physician's orders? And, engaging patients and families in their care, educating them, letting them have access to their discharge instructions, to be able to securely message their physicians, to be able to look up content that's been kind of approved or blessed by your health system is very important, because as this new generation that's growing up that's fully connected and it prefers to do their interactions electronically, they're going to demand these technologies. They're going to demand access to that information. So I think we need to provide it. And although, I usually hear, well, we have all elderly patients, they won't use the technology. Well, their families will, and the next generation will. So I think engaging patients and their families, building out patient portals that are very robust and very interactive and meets the needs of our customers is very important. And as I mentioned before, it's for the individual solo practitioner physician, it's going to be incredibly hard to meet all these measures, to make all these investments, to stay on top of all these regulations and still survive. That's going to be a big challenge. And I think you're going to continue to see consolidation in the small to medium-sized markets where it's just too much. They're overwhelmed. So unfortunately, the days of the individual practitioner, they may be numbered. Some of them may be well-positioned, but I would say across the boards, many of them are going to be signing off to be acquired by larger groups or be acquired by larger hospitals and health systems. Which, again, my last bullet point there is it's going to force tremendous consolidation, and I think we're already seeing that. I think that's my last slide. So, Kate, are you ready to open this up for Q&A?
Sure, yeah. Thanks so much, Tom. A lot of really great stuff there.
Thank you.
Just as a reminder to everyone, click on the Q&A panel located in the right corner of the screen and type in your questions in the text field and hit send, and keep that default as all panelists. So one of the first things I wanted to ask you about was the vendors, and you talked about keeping pressure on the vendors and not being afraid to escalate an issue. This seems like something that could get a little tricky. Can you talk about how you navigated that situation?
Sure, absolutely. Well, the key is that I've worked very hard to build strong relationships with the senior executives at the organizations that we deal with. So I already have a well-established relationship, which means a lot going into this. So when I call and I escalate, they already know who I am. They already know what I'm working on. And having that as a backdrop is very important, because I let them know right up front, we want to be a leader in this. We want to be one of the first to make this happen. We're very committed to this, and we're going to make sure that you deliver the code. So I try to weave that into contractual language. I have regular meetings and communications about what our goals are and what our expectations are for our vendors. If you wait till the day you're, ready to load the code and you're, on their website searching for names of people to call, you're not going to be very well positioned to get their ear and get them to actually do something. So, and like I started off, we've been working on this for 5 years to get to the point where we can be one of the first to do this. If you're trying to do it in a 30-day time span, it's probably not realistic. So having those relationships with the vendors, letting them know what you're trying to do and what you expect of them, I think is probably the critical first step to making them actually be responsive.
Right. Okay. Now, a question just came in about the portals. What did your patients look for initially in the portal?
Yeah, that's a great question, and it's really an education because they're under the impression they can get their entire medical records, as I stated, and you have to be very careful in that you describe what the capabilities are and where we're ultimately trying to get with that, because there are patient portals out there that literally can do many, many things. You can register, you can pay bills, you can message your physicians, you can look up all kinds of information. So you have to make sure that you know the capabilities of your portal, that you advertise and educate patients what those capabilities are, so where the value would be for them, and then ultimately what your development plans are, what's coming next, to make sure they know it's not just static and that's what it's going to be.
Right. Okay, so there's a lot of focus on patient engagement, but some think that the patient who doesn't have a critical condition doesn't want to be involved. What do you think about regulators holding hospitals responsible for patient engagement?
Ultimately, they're holding us responsible, but we also have the responsibility to keep our patients informed and educated. And so the government's just making us do something we should be doing anyhow. When I sit down and talk with the physicians, many of them say, I don't want my patients to know what's going on. That's the wrong approach. Because if you get some highly educated and sophisticated patients, they're going to demand to know what's going on. They're going to do their own independent research. They're going to seek physicians that want to share information and work with them. Unfortunately, we don't have the luxury of being able to just say, well, let's keep our patients uninformed and uneducated because it's easier for us. So, you may not like the government regulation saying you must engage your patients, but ultimately, if we're going to get control of the cost, if we're going to control the growing demand for services where we start to get on the front end of preventative medicine, wellness, making sure patients are following the protocols and compliance, we can't do this alone. We have to engage our patients, and we have to work with them. Not everyone's going to go along, but we better make sure we've done everything we can to educate, inform, and include patients in their care. It's just not optional anymore. Right.
Okay. So your organization, it's not a large organization. Can you talk about the meaningful use project team you had, and just as far as who were the key people and kind of how much you communicated with them?
Sure. So I have a very strong relationship with our CMIO and our CNO, which we've built over many, many years. So the three of us worked very carefully to make sure the entire senior leadership team and the board of directors were kept up to date and informed on a regular basis of our goals, our expectations, and how we were doing, so the regular progress. And then within the actual IT department, I have a very strong cross-functional team of clinical background and expertise, technical background and expertise, and strong project management. So basically that group worked very carefully to look at each measure, engage the vendors, because if that vendor engagement isn't there and they're not sitting at the table with you, you just lose too much time trying to interpret the regulation and then make sure the coding that's actually deployed in the EMR matches that interpretation and can be delivered that way. So that was kind of our cross-functional team of having the appropriate senior leaders engaged and involved, and then having the right technical people involved. And then across the boards from our organization, we have a standing clinical integration committee with all the key representatives from all the functional areas that are kept up to date and informed on a monthly basis.
Okay. So you had brought up one of the big challenges of Meaningful Use 2 was data exchange. And as far as the engagement with community physicians and what needed to happen, any kind of best practices for approaching those conversations?
Sure. The number one I'd say is get them involved early. So the sooner you can get physicians involved to find out what their expectations are, what they're trying to accomplish, are they pursuing meaningful use, and if so, how aggressively, what EMRs they have, what capabilities they have as far as are they able to receive an HL7 transaction? Do they have to have some kind of batch upload done? How far along are their vendors? And you're going to get a cross-section of that, so that's why it was important for us to engage them, understand their capabilities, prioritize what EMRs we can work with, what physicians are the most interested and aggressive in pursuing it, and then what their capabilities are, because some can do HL7 interfaces where we can send an outbound lab feed, we can send an outbound RAD, we can do patient updates as far as ADTs, and other ones have to get web inboxes where they have to log in to get the information into a website because they just don't have the capabilities to accept those real-time feeds. So you need to know where your docs are at and prioritize them and then create solutions that basically meet their needs. And it's not going to be a one-size-fit-all. You're going to have multiple options to be able to satisfy their requirements.
Okay. So now you talked a little bit about the huge increase in IT spend. How one attendee wanted to ask, how much of an increase did you experience in your IT budget?
We went from being 0.5% of our operating budget to almost 8%, and that was sustained for 3 years. Now it's down to about 2% now, but we literally absorbed almost the entire capital budget for 3 years, which was fiscal year 10, 11, and 12, to basically rip and replace all of our infrastructure. So all of our routers, switches, wireless, Wi-Fi, new computers, new servers, new internet connections. They were expanded. It was a tremendous investment in infrastructure to position us to be able to do what we want to do. And then, of course, all the purchases with the EMR providers to get the appropriate modules, to do the upgrade, to get the certified code. Tremendous amount of professional services and outside consulting was brought in to get everything up to speed. A lot of testing has to be done, especially when you're the first one in, to make sure that the code's functional and works. So it's just there's no way around it. If you don't have the resources to do it, it's going to be incredibly difficult to get it done right and then position you to go forward. So we wanted to try to address everything right out of the gate and not do it in an incremental approach. We want to do a big bang, do it right, do it the first time, and then we're well positioned, and that's the approach we took.
Right, okay. Now, you had mentioned that you received the maximum meaningful use incentive dollars. How will you evaluate your interest in stage 3? Any reason to participate? Any upside there?
Well, certainly we want to comply with the measures. We're not going to purposefully say, well, there's no money, so we're just going to drop it. I think it's remembering that the core reason to do this is to increase patient safety and quality. That's still very important for us. Since we've already made 95% of the investment, if stage 3 is an incremental increase of stage 2 and we don't have to make major investments in doing it, I don't see any reason why we wouldn't try to be fully engaged, adopt the measures, attest, stay on the good side of ONC, and reap the benefit, because if it improves safety, patient safety and quality, and positions us even better in the marketplace, of course we're going to do that. Would we spend, millions and millions of dollars to do it just to do it? Probably not.
Yeah. Okay. Now, you talked about going for HIMSS stage 7. You said you're 6.5 right now. Have you found that meaningful use and HIMSS analytics work well together as far as those two benchmarks?
They do. There's some things that are a little outside of meaningful use that they're patient safety and they're important, but they're not specifically addressed in meaningful use. But at the end of the day, the cores are the same, and that's they're looking at automating clinical practice to deliver patient care. So sometimes automation is automation for itself, or it's a productivity thing or an efficiency thing, but not directly related to patient care as far as safety or quality. But they're not divergent. I would say they're slightly overlapping, if anything.
Right. Okay. So you had said that you think ONC is going to lower the bar and provide more flexibility ultimately. Now, do you think that there's a downside to that as well?
Absolutely. I think it's going to take the focus off meaningful use. You may see some backsliding where people have successfully attested and they don't really meet the measures anymore. So they may have focused for that 90 days and they met the mark and they submitted their attestation and they got their money. Well, go back 3 months from now and check where they're at, and they may not even be doing half of it anymore. So it's the challenge of how do you keep the momentum? How do you keep engaging patients and their families? So if they said the bar is 5% and you did 7%, well, 6 months from now you should be doing 10%. Is that the case, or is it going to slide down to 1%? So my fear is that when you take the millions of dollars of incentives away and you lower the bar, it's a signaling that well, this is not as important as it was before. We got our money. The penalties aren't really that important. Hey, we got bigger things we need to work on. So I am very afraid that you're going to see backsliding. You're going to see a plateauing of investment. You're going to see focus shifting to other things that are, let's say, more important competitive market forces, ACOs, patient-centered medical home, bundled payments, health system acquisition and growth, insurance exchanges. There's so many things that you could mention that could derail meaningful use that I am afraid of that. And we've spent so much and had so much of a focus on it that I would hate to see that happen, because our patients and families are the beneficiaries.
Right.
They're the ones that get safer care. So it is an important thing to keep going.
Now, one of the big focuses for your organization in stage 1 was to kind of, go beyond those minimum requirements and, go for 100%. Yeah. And is that something that's going to be continued to, guide your strategy?
We try to keep that spirit, but we, to be honest, are under the same pressures as everybody else. It's going to be very hard to be pushing physicians to the break point when we have ICD-10 coming too, which is going to be something that we're going to have to spend a lot of time and effort training our physicians, modifying their workflows. So I would like to say we can continue that spirit, but the reality is we're under just as much pressure to refocus our energies and focus our resources in other areas. So we might not have the luxury that we did in stage 1 and 2 to far exceed to position ourselves for the next stages. It's going to be challenging. It's going to be harder than ever.
Yeah, you can't be 100% in every area at the same time.
Right, you can't.
Okay, well, I think that should about wrap it up. Thank you so much for Tom for providing all these insights. We really appreciate it. For all of those listeners, you're going to receive an email when our archive recording is ready. And for the Chime CHCIO credits, the attendees will all receive 1 credit. If you have any questions or comments, please email Anthony or myself. And go to healthsystemcio.com/webinars to view our upcoming schedule and see the last 12 months of archived events. Thanks again, Tom. And thank you, everyone, for joining us today.
Thank you, Kate. It was my pleasure.